So today I'm going to try and give you all a brief overview of myeloma, so we're all on the same page. And then I'm going to focus a lot of time on talking about how I approach the initial treatment of people who are recently diagnosed with myeloma, because I think that's really where we can make cure happen. That's the space in which we can really impact people's lives and give them really long periods of remission. And then finally, because we've had so many changes and so many new drugs in the last 2 years, I'm going to talk a little bit about some of the treatment considerations when the disease returns. So myeloma, when we talk about blood cancers, is actually, to me, a very common disease. There are almost 100,000 people living with myeloma in this country. And we expect that in 2016, there's going to be 30,000 people diagnosed with myeloma. So I think as blood cancers go, it's very frequent, but I'm always surprised when I see patients who have recently been diagnosed or talk to their families. I'm always surprised by the number of people who haven't heard of myeloma. So I think it's a disease we need to really talk more about and try and raise awareness about. So I want to talk a little bit about some of the initial symptoms that patients come to us with. Myeloma is a cancer of a cell called the plasma cell. And the plasma cell is a normal part of our immune system. When they grow abnormally in myeloma, you'll see on the far left, they take up space in the bone marrow and they stop normal bone marrow function. And many people have low blood counts when they come and see us. And that's common for blood cancers. However, myeloma otherwise is a very peculiar disease, and it causes a lot of other very strange symptoms. So by growing in the bone marrow cavity and by secreting some hormones locally in the bones, it actually causes damage to the bones. It causes these punched-out lesions that can weaken the bones and can lead to fractures. Moving on, myeloma is also a cancer that suppresses the immune system. So there are patients who initially come to us with signs of infection. And then finally, there's this strange thing called the M protein, or the monoclonal protein, which can damage kidneys and actually lead to nerve problems in the fingers and toes. So I want to talk a little bit more about the M protein because I think it's something that's really important in following the disease, but it's also a bit of a strange concept amongst blood cancers. So what is the M protein? So the normal plasma cell makes this guy on the far left called the immune globulin. And the top end of it normally sticks onto things like bacteria and viruses and helps us fight infections. But in myeloma, we make a lot of this protein, and it doesn't really help to fight infection at all. It can cause kidney problems, but on the upside, it is something that we can measure. It's something that we can measure in the blood and the urine, and it helps us make the diagnosis, but it also is a useful way of following the disease. So we know that as the disease grows, this number might go up, but as the disease is treated and goes into remission, the number goes down. So I want to show you that in a schematic. So along the top are the different steps in myeloma, all the way from asymptomatic people on the left to people who have advanced myeloma. So on the bottom is a chart that shows the M protein. So as people develop symptoms, the M protein increases, and once people are treated, it goes down, and this is the time, the initial phase of treatment, where I think we can really start to talk about a cure. So I want to focus most of the talk on speaking about how we approach people at this time point. So I'm going to pose a few questions, and these are questions that I ask myself, but there are questions that you could ask yourself as you are first treated. Question number one is, do I have myeloma that needs to be treated? Do I have the symptoms that need to be addressed? The second question is, what is my prognosis and what stage am I at? The third question is, am I eligible for this treatment called an autologous stem cell transplant? And the fourth question is, what are the best drugs for me to receive as part of my initial treatment? So question number one, do I have symptoms? So for many, many years, and still in 2016, we wait for people who have myeloma to develop problems from that disease. There are many people who have asymptomatic myeloma for many years, and still in 2016, we don't tend to recommend treatment for those people. So we wait to see these criteria, the CRAB criteria. And basically, that stands for having a high calcium, having renal impairment or kidney disease, having anemia or low hemoglobin, or having bone lesions. So you have to have one of these for us to think that you should receive treatment. And this was true for many, many years, and then very recently, this has been revised. So there are now also 3 additional criteria. So people call this the slim crab. And the additional criteria are having a lot of plasma cells in the bone marrow, having a light chain ratio, and this is part of the measurement for a monoclonal protein, having a very abnormal light chain ratio, or having bony disease, very small lesions on an MRI of the spine. So these are the new criteria we use to decide if people have symptomatic myeloma. So that's the first question. Do I have symptomatic myeloma? The second question is, what is my prognosis, or what is my stage? So I wanted to show you how much things have changed in this disease over the last 20, 30 years. So this is what we call the 5-year survival, or the number of people with myeloma who are alive 5 years after the diagnosis. And you see that in the 70s, 80s, 90s, it really didn't change too much. But in the early 2000s, we started to get new drugs and new approaches to treating myeloma, and the survival improved. And you'll see in 2008, it reached about 50%. And that's not a home run, but it clearly is much better than before. And now I think it's reasonable in 2016, because this data ends in 2008, it's reasonable in 2016 to tell people that the 5-year survival is approaching 60 to 70%. That's a reasonable thing to tell people nowadays. So again, not a home run, but we're getting better and better. So there are ways to individualize that and figure out on a patient-to-patient basis what the prognosis is. So this is a thing called the International Staging System. There are 3 stages, stage 1, 2, and 3. And it's a very simple staging system that basically needs 3 blood tests and a sample of bone marrow. So the 3 blood tests that are very standard blood tests that should be done at initial diagnosis are the beta-2 microglobulin, an albumin level, and now also an LDH. These are 3 very standard blood tests. In addition, when you add this thing called the karyotype, which is a test that's done on the bone marrow at diagnosis, we can kind of stratify people into lower or higher risk, and we can give you an idea of what to expect from treatment and what prognosis might be. So that's the second question. How do we prognosticate people? The third question is, am I eligible to get this treatment called autologous stem cell transplant? I'm sure many other people are going to talk about a similar concept later on today. When this treatment was first developed, it was a treatment for patients up to age 60s, maybe 65. But now we know that it's not really fair to use an age cutoff. It's more about how fit people are. So in fit people all the way into their 70s, we think that this is still a treatment that has some value. And of course, there's also the element of people being able to choose what they want, because we have many treatment options. So I want to just, because autologous stem cell transplant is still very important in this disease, I want to just talk a little bit about autologous stem cell transplant and what it is. And I'm sure other people will touch on this, but I think it's really important in myeloma specifically. So the concept of autologous stem cell transplant is really to be able to give a really large dose of one chemotherapy that works really well in myeloma. That's a drug called melphalan. The problem is when you give a very large dose, it has a really bad impact on blood counts. And actually, the blood production in the bone marrow can stop completely. So if we actually take out the blood production in the form of taking out blood stem cells, we can collect them, they can be stored, and they stay healthy. Then we can give people chemotherapy, and then the very next day, give them back their own blood stem cells. What happens is, over the next week or so, the blood counts go down, but about 10 to 14 days later, the blood counts go up. So I made it sound very simple, but obviously there are risks to going through this procedure. The risks we feel now are that many people have to spend some time in the hospital. There are the side effects of conventional chemotherapy that we've all heard about, things like infection, things like irritation of the mouth and irritation of the gut. But we think on the whole this is a much safer procedure than it used to be. In terms of benefits, there are some very real benefits. Even though this is a treatment that's been around for 30 years, it's still a treatment that affords people a really long period in remission. As Dr. Stipp mentioned, there are people who have undergone autologous transplant and are still in remission 10, 15, even 20 years later. And those people may be cured of the disease. So the fourth question was, what is the best treatment at the beginning of the disease? I think this schema gives you an idea of what many of us recommend for people who can undergo a transplant. So we tend to recommend a few months 3 or 4 months of treatment at the beginning, followed by a more intensive phase of treatment of autologous transplant, and then to use a strategy known as maintenance to continue a low-intensity form of treatment. We know using this type of treatment paradigm, we can really provide long remissions. So as well as getting new drugs, we've also, I think, learned to use them in a different way. For people who either choose not to or are unable to undergo a transplant, there's not a big change. We tend to prolong this treatment at the beginning, maybe 6 months or a year, and then we similarly tend to like to continue more prolonged, lower intensity treatments that again can keep people in remission for a long time. So the only difference really is dropping out the transplant. So let's talk a little bit more specifically about what drugs should be used. I think to just talk about broad concepts, there are a few important things to talk about. We have many new treatments and many new drugs. So there is a discussion about should we use 1, 2 drugs, should we use 3 drugs, and I'm going to talk a little bit about that in the next slide. Obviously, many people with myeloma have some element of kidney problems, and that impacts what medicines we can give people. So looking at what the kidney function is before deciding upon the treatment regimen is important. And then we all understand there are some very real considerations. We understand that getting some treatments you have to be in the office, whereas others are pills, and that is an element that is very important to some people. And then obviously cost sometimes comes into it, and things like copays. So there are also very real-world considerations for us. So let's talk a little bit more specifically about the drugs. This is not an exhaustive list of all the medicines we can potentially use, but I think it just gives you an example of the most commonly used medicines. So in the 3 boxes here, you'll see steroid medicines, which are still an important part of treatment of myeloma and have been for many years. There is a group of drugs called the immunomodulatory drugs, for example, lenalidomide. And then there's a group of drugs called the proteasome inhibitors, and an example of those is bortezomib. Now, in general, we combine steroids with 1 or 2 of the other medications. And we think nowadays using 3 medicines in a row, all at one time, tends to give people deeper responses and longer remissions. Obviously, though, when you add 3 drugs together, you'll see in the boxes there are side effects of these. So steroids often come with side effects of affecting blood sugar and weight gain. Many of the immunomodulatory drugs can bring blood counts down, and they also come with a risk of blood clots. And finally, some of the proteasome inhibitors can affect the nerves in the fingers and toes and cause a thing called peripheral neuropathy. So using more drugs obviously also does come with a bit of a cost. I want to finish off this part by just talking about the way we use these medicines. So in general, previously in myeloma, we weren't using long courses of therapy. We'd try and get a response in the disease, and then we'd stop. But nowadays, with these drugs that don't carry that many side effects, we tend to try and prolong treatment for as long as possible, and that's the principle of maintenance therapy. So we use an initial therapy to try and reduce the disease as much as possible, and then a more prolonged phase where it's less intensive, hopefully still maintains quality of life, but keeps patients in remission for much longer. And some of the studies, this has been very well studied now, some of the studies show that the periods of remission can be doubled by using this strategy. And I want to just finish off by just saying it's important to also consider things like supportive care. So it's not just about the treatment, it's also about trying to protect people from the side effects of treatment. So occasionally a physician may ask you to take medicines that may prevent infections. So medications like bortezomib can be associated with things like shingles, so we use an antiviral to hopefully prevent that. The immunomodulatory drugs can cause blood clots, as I said, so oftentimes we recommend patients take some kind of blood thinner, either an aspirin or a stronger blood thinner. And also bone health is really important. So medicines like the group of drugs called bisphosphonates are important to try and preserve bone health and make bones stronger. So I think I probably just have a few minutes left, and I just wanted to quickly talk about if the disease comes back and what the treatment considerations are then, because we now have so many options. The first thing to talk about is whether treatment is needed straight away. So measuring the M protein is a very sensitive test and gives us an idea very early that disease may be returning. But that doesn't necessarily mean that treatment should be started straight away. So oftentimes those numbers can be watched for several months before treatment is started. But if treatment is needed, what are the considerations? Well, a lot of the things I already told you, the number of drugs to use, convenience, cost, but also these are some additional ones. So obviously still kidney function and looking at whether drugs can be gotten rid of from the body effectively, but also what are the side effects that people got when they first got treated. We don't want to use medicines that have overlapping side effects with medicines that were used early on. And then finally, if there was a really long period of remission, for example, after transplant, if the period of remission was on the order of 5 years, oftentimes we actually say after 2 years, it's worthwhile considering going back to the same medicines because often they work very well. Here are the names of many of the new drugs that have been approved. This is just in the last 2 years. And I'm happy to talk to anyone about specifics about these drugs. This could be an hour-long lecture by itself. But the point is that there are many, many, many options. There is more than one way to skin a cat. And each of these comes with pluses and minuses. So it's really a big discussion nowadays because we're lucky, I think, to be spoiled for choice in the relapse setting now. So I just want to summarize by saying I hope I've convinced you that nowadays people with myeloma can really look forward to very prolonged periods of remission. And the way we achieve that is by trying to get a really deep response and trying to prolong it with less intensive therapies. And if the disease does come back, there's still a lot of hope. There are still many, many drugs, and there are many more coming that are very effective in people who have relapsed myeloma.